Good morning. On behalf of UNETSYS, I would like to welcome you to the special session. Today, the topic of interest is autoimmune liver disease, clinical insights into PBC, PSC, and AIH. And we have the distinct honor to have Professor Michelle Shiffman. Dr. Shiffman is the director of the Liver Institute of Virginia at the Bon Secours Mercy Health in Richmond in Virginia. Dr. Shiffman graduated from the State University of New York, Upstate Medical Center in Syracuse, and then did residency training in internal medicine and fellowship training in gastroenterology and hepatology at the Medical College of Virginia in Richmond. From 1990 to 2009, Dr. Shiffman was on the faculty at the Virginia Commonwealth University Medical Center, where he served with the Chief of Hepatology section and Medical Director of the Liver Transplant Program at VCU Medical Center. Dr. Shiffman has published over 300 articles in peer-reviewed medical journals, invited reviews, and book chapters, has edited 3 textbooks on liver disease, and has been a guest editor for 2 issues in Clinics in Liver Disease. Dr. Shiffman is a fellow of the American Board of Internal Medicine and the American Association for the Study of Liver Diseases. He is a master in the American College of Gastroenterology, where he served as a member of the Board of Trustees from 2004 to 2009. With that introduction, I would like to welcome Professor Shiffman, and over to you, Dr. Shiffman. You can share your screen at this point.
Great. Thank you, Sanjaya, for inviting me to present to this group and to have this information stored in this vast library of content for people to review in the future. Can you see my screen okay?
Yes.
Okay, great. My topic today, Sanjay has asked me to talk about autoimmune liver disease, and I'm going to specifically, I've got something over my screen. I can't move it. There we go. I'm going to specifically talk about clinical insight into autoimmune hepatitis, PBC and PSC, and share with you some insights that I've learned over 30 years of being a hepatologist. So these are our 3 major autoimmune liver disorders: autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. You can see the prevalences there on the top line. The most common of these 3, autoimmune hepatitis, and PBC and PSC affect roughly equal numbers of patients in your area. There's no specific country or geographic prevalence of any of these diseases. They're all worldwide seen in similar rates, maybe except for PBC, which seems to be a little bit more common in Norwegian or ancestors from the Norwegian area of Northern Europe. Both autoimmune hepatitis and PBC affect women more than men, and PBC is really a prominently woman disease. 95% of patients are women, but it's important not to forget those 10% of men. And recent studies have demonstrated that men are not diagnosed as quickly with PBC because it's not thought of as often, because it's so uncommon in this disorder to be male. But clearly a male with cholestatic liver disease, part of the testing should include testing for PBC. PSC tends to be more evenly dispersed between women and men, but there is a slightly male predominance, with about 2/3 of the patients being men and 1/3 being women. The onset of the disease for autoimmune hepatitis is typically this bimodal distribution, where you can get the disease in your teenage and early 20s, and then there's another peak in the 40s, rarely seen before the teenage years, rarely seen actually in the 30s for some reason. But one of the age groups that we continue to see autoimmune diseases in general is older individuals, and we have patients now diagnosed with autoimmune hepatitis and PBC in their 60s, 70s, and even into their 80s. PBC is generally recognized in the 40s, and PSC may be a little bit younger. All of these disorders are autoimmune, and autoimmune diseases are all genetically based. And as a result, there are specific ALA associations with all three of these disorders, as I have listed there in the table. They also have associated immune disorders. Autoimmune hepatitis can be seen with lots of different coexistent autoimmune disorders. Autoimmune skin disorders, such as psoriasis. Autoimmune joint disorders, such as rheumatoid arthritis. Thyroid disease is common as well. For PBC, there are three main autoimmune diseases which seem to be more common than anything else, and that's rheumatoid arthritis, thyroid disease, and Sjogren's syndrome. For PSC, the most common associated autoimmune disease is inflammatory bowel disease. And many of these individuals with PSC are recognized by gastroenterologists who follow their inflammatory bowel disease. 80% of these patients have coexistent ulcerative colitis, another 20% Crohn's disease. Almost universally, patients with PSC will have some sort of inflammatory bowel disease. The serologic patterns for these disorders: for autoimmune hepatitis, many of the patients are ANA positive, but more commonly, smooth muscle antibody is much more specific serologic test for autoimmune hepatitis than is ANA, which is a very general, non-specific autoantibody seen in multiple different autoimmune disorders, including our other two autoimmune liver disorders, PBC and PSC. The very specific serologic marker for PBC is an anti-mitochondrial antibody, and the very specific serologic marker for PSC is the ANCA. Each of these disorders have specific histologic presentations. For autoimmune hepatitis, it's a hepatocellular infiltrate, portal inflammation on liver biopsy with interface hepatitis and piecemeal necrosis seen on the biopsy. The biochemical pattern for PBC and PSC tends to be either cholestatic, but can be very mixed in individuals with PSC. The diagnostic tool for PBC would be an elevated alkaline phosphatase and an anti-mitochondrial antibody. The biopsy would show inflammatory cholangiopathy with destruction of bile ducts by infiltrating lymphocytes. For PSC, the diagnostic test is an MRCP showing bile duct strictures that are characteristic of PSC. These can be in large bile ducts, small bile ducts. We'll talk about that a little bit more later. And on liver biopsy, the histologic characteristics are portal fibrosis and non-specific portal inflammation. There's nothing diagnostic about the biopsy in PSC, except maybe increased fibrosis in the portal tracts, more than you would expect for the degree of inflammation. So that's an overview of those three disorders. And what I'm going to do now is talk about each one individually. We'll start with autoimmune hepatitis. So autoimmune hepatitis is divided up into two basic types. Type 1 is the classic autoimmune hepatitis, originally identified and described by Dame Sheila Sherlock way back in the 1960s. These individuals have positive serology for anti-nuclear antibody and or smooth muscle antibody, but the smooth muscle antibody, as I mentioned a few minutes ago, is much more specific. However, it's important to remember that 20% of these patients have no serologic markers of autoimmune disease. These patients are identified because they have elevated liver transaminases, maybe abnormal imaging of unclear etiology, and a liver biopsy would be diagnostic, showing histologic features of autoimmune hepatitis. Type 2 autoimmune hepatitis is a specific entity that's very uncommon in the United States and Canada, but is mostly seen in Southern Europe. More common in young women, although autoimmune hepatitis more common in women anyway, but very rare to see a male with type 2 autoimmune hepatitis. And the characteristic serologic pattern for this is an anti-liver kidney microsomal antibody, or LKM, or anti-LC liver cytochrome antibody 1. There are some reports that type 2 autoimmune hepatitis tends to be much more severe and rapidly progressive. However, this may be due to bias because there's really no controlled studies comparing it to type 1 autoimmune hepatitis. The table at the right shows the simplified scoring system that has been developed for autoimmune hepatitis. And basically, if you have a positive, and this looks at antibodies, serum levels of immune globulins, histologic features on liver biopsy, the presence of viral disease, and we add those up to get a diagnostic score. You can see that the more specific smooth muscle antibody, an LKM or SLA, gives extra points, whereas the ANA more nonspecific, just 1 point. If the immunoglobulin levels are very high, an extra point. Histologic features compatible or typical of autoimmune. No markers of viral hepatitis. And you add your points up, and if you're more than, if you have 6 points, excuse me, if you have 6 points, this is probable autoimmune hepatitis. But if you have 7 or more points, this is definite autoimmune hepatitis. And this can help you really nail down the diagnosis by adding up your points when you have some nonspecific or other features. Maybe the patient's overweight, maybe you're thinking of fatty liver disease, maybe there's some inflammation on the biopsy and serologic markers. And so this would help you sort out autoimmune hepatitis versus something that may be coexistent or in the background. There are basically 2 presentations of autoimmune hepatitis, what I refer to as an aggressive presentation and the indolent presentation. The aggressive presentation is the one we talk about all the time and are in the textbooks. Easy to diagnose. Patients present with marked elevated liver transaminases, typically over 500 and maybe up to 1,000. The total bilirubin may be normal, but it's usually elevated to some degree, either mildly or can be as high as 15 or higher in severe aggressive autoimmune liver disease with multilobular collapse on liver biopsy. These patients typically present with weeks to months of a prodrome, or what appears to be a viral syndrome, and many of these patients may be mistakenly diagnosed as simply having elevated liver enzymes due to a viral syndrome, but the problem is the viral syndrome just doesn't go away. They continue to have arthralgias, myalgias, fatigue, the liver enzymes continue to go up, the bilirubin goes up, and then you eventually realize this is not a viral syndrome, this is something not right with this. Hopefully by now you've gotten your serologic studies for anti-nuclear and smooth muscle antibody. If they're normal, that now points you in the direction of autoimmune hepatitis. A liver biopsy in this aggressive presentation will show severe portal inflammation, interface hepatitis, piecemeal necrosis, and lobular collapse in the most severe forms. Fibrosis may be variable. If this is a really acute presentation, there may be no fibrosis, but many of these patients smolder with nonspecific flu-like symptoms, some fatigue for many months before they're actually diagnosed. And these patients may have a more significant fibrosis on that first liver biopsy and that diagnosis. And many of these patients may also have chronic inflammation, chronic hepatitis with mild to moderate elevations in liver enzymes, kind of like the indolent presentation I'll talk about in a minute. But then all of a sudden, after months to years of these mild elevated liver enzymes, they'll suddenly flare into this aggressive pattern, and they may already have cirrhosis at that point. These patients that flare with cirrhosis can then develop acute liver failure. This is a rare presentation of autoimmune hepatitis. It's very severe and needs to be recognized. And if these patients don't respond to immunosuppression fairly rapidly and develop as signs of liver failure with coagulopathy and hepatic encephalopathy, they need to be transferred to a liver transplant center rapidly so they can get emergency liver transplantation. These patients are identified because they're symptomatic and typically very symptomatic. In contrast, the indolent presentation of autoimmune hepatitis, the liver transaminases are mildly elevated, 50 to 100. Their bilirubin is always normal. They're minimally symptomatic for months to years, maybe fatigue, maybe some arthralgias and myalgias on and off for many years. And when you finally get around to doing the liver biopsy, they have mild to moderate inflammation, typically fairly mild with portal inflammation. But if they've had this indolent presentation for many decades, they could have more inflammation and they could even have cirrhosis. These patients never develop acute liver failure, and they're identified by blood testing showing elevated liver transaminases and/or imaging showing signs of chronic liver disease, possibly already cirrhosis. So the next several slides are going to go through treatment of the acute onset type of disease, the aggressive form of the disease. And here you have a typical example, liver transaminases in the blue dots and the blue line that are starting up in about the 900 range. The biopsy is made, is done, and the diagnosis of autoimmune hepatitis is confirmed. And then you start the treatment with prednisone. Typically, you would start with a dose of about 60 milligrams, and the initial dose of prednisone that you select, or that I select, tends to be in proportion to the degree of elevation of those initial presenting elevated transaminases. So transaminases above 800 up into the thousands, I'll start with 60 milligrams prednisone. Maybe if it's over 1,000, I may start with and the patient is hospitalized for jaundice, I'd start maybe with 100 milligrams of Solu-Medrol IV. So the more severe presentation, the higher the dose of immunosuppression you want to start with, the higher the dose of prednisone, and maybe even Solu-Medrol if the patient has marked elevation transaminases and is jaundiced. In any event, and as the liver enzymes are a little bit lower, maybe in the 500 range, you could probably start with 40 milligrams of prednisone. Autoimmune hepatitis is pretty easy to treat. You can make some mistakes, but in general, the vast majority of patients respond almost no matter what you do. So this patient here with liver transaminases in the 900s was started off on prednisone, and generally you'll reduce the prednisone by about 20 milligrams every 2 weeks, stepwise down to 20 milligrams per day. If the liver enzymes are still elevated at 20 milligrams per day, then they don't come down any further and they don't normalize. Then you need to add a second drug, and that's typically azathioprine. However, more and more hepatologists will use mycophenolate mofetil or Cellcept in exchange for azathioprine because you don't have to worry about checking levels. You don't have to worry about pancreatitis as a side effect. Mycophenolate mofetil, a much better tolerated second-line agent, in my opinion, I would think in many hepatologists' opinion. Now, you can start this second-line drug, azathioprine or mycophenolate, MMF, either at the start of therapy if you think this is a fairly aggressive form, or you can taper your prednisone down to 20, and then you could add prednisone or add the second-line drug when the prednisone dose is 20 milligrams. The most important thing you should not do is lower the prednisone below 20 milligrams if the liver enzymes are still elevated. You will never get the liver enzymes normal if you lower the prednisone down too soon. You've got to wait for those liver enzymes to come down. And if they don't come down with prednisone alone, you need to add that second-line drug and then continue 20 milligrams of prednisone until the liver enzymes do come down. Now, in this example, you can see that the liver enzymes came down very, very nicely. By the time we hit 20 milligrams of prednisone, the liver enzymes were normal already. And so we tapered prednisone down to 20 milligrams, and second-line therapy was never added in this patient. We continued the prednisone out to 12 months. And there goes the second mistake you can make, is stopping prednisone too soon. So this slide looks at the most common mistakes you can do when managing, or you can make when managing autoimmune hepatitis. One is stop treatment too soon. The initial treatment with prednisone plus or minus azathioprine or Cellcept should be continued for 12 to 24 months. Number two is you can, if you do get a relapse after you stop prednisone, as you've seen here, you can see the prednisone was stopped at 6 months, stopped too soon, and the liver enzymes flared up. And so what happens is the patient was simply put on an ineffective low dose of prednisone, 10 milligrams in this example, and you can see the liver transaminases never really came back down. So that's the second mistake you can do, retreating with too low a dose of prednisone. In general, a patient that relapses needs to be recycled, not starting at 60 because the liver enzymes are going to be fairly mild, as shown in this example, when you recognize relapse. But you've got to go back up to at least 20 milligrams of prednisone when you retreat. And then the third mistake you can do is not adding a second drug when retreating. So if you didn't add a second drug on the first go around and you relapse when you finally stop your prednisone, you're going to need to retreat with prednisone, recycle at 20, and add that second drug at that time to prevent relapse again. This shows the correct way to retreat after relapse. Relapse, as I mentioned earlier, needs to be retreated by recycling with a minimum dose of prednisone of 20 milligrams a day. If the patient was lost to follow-up and they flared with liver enzymes much higher, well, then you may want to start with 40 or 60 milligrams of prednisone, depending upon the level of those liver transaminases when the patient comes to you with that flare. You need to add that second drug. You need to add azathioprine or Cellcept, if not utilized in the first course. You need to keep the patient on longer-term immunosuppression so they don't relapse. So if you stopped at 6 months before, you need to go longer for a year. If you went for a year with 2 drugs and they relapsed, well, then you need to choose maybe a different agent. So if you're intolerant to prednisone or azathioprine, there are other drugs you can try, such as budesonide. I've already mentioned mycophenolate mofetil in place of azathioprine. And what I personally use a lot of in patients that are resistant to prednisone, I go right into calcineurin inhibitors, particularly tacrolimus, which is very well tolerated, and you can get by with lower doses than we use in our liver transplant, kidney transplant recipients, with serum levels in the 2 to 4 range, will generally control autoimmune hepatitis exceedingly well. And when I have a patient that's just resistant to prednisone, or they keep relapsing when I try to get off prednisone, I'll quickly switch over to tacrolimus. If intolerable to tacrolimus, then I could use cyclosporin as a backup. There are some patients, as I've mentioned, that are resistant to treatment, and patients who fail to normalize their liver transaminases after 6 months, you shouldn't maintain them on high-dose prednisone forever. You can't stay on 20 milligrams of prednisone year after year after year. If you don't normalize your liver enzymes on prednisone within 6 months, you need to think about switching to an alternative agent. And one alternative agent would be budesonide at a dose of 9 milligrams q.day. In a randomized controlled trial, budesonide was shown to be as effective as prednisone. I don't think it's any better than prednisone, but it does have less side effects. It's much, much easier on the bones, but it does still cause some glucose intolerance, and the glucose may need to be treated if it remains elevated on budesonide. You can switch mycophenolate mofetil for azathioprine, or as I've already mentioned, you can use a calcineurin inhibitor, which is my go-to. I find budesonide very, very expensive for many of my patients, whereas tacrolimus is generic and tends to be a lot cheaper. Now, there are some patients that really have a mild, when you evaluate them, they really have a mild form of autoimmune hepatitis. And the issue is, if the autoimmune hepatitis is really mild, do they really need to be treated with immunosuppression, which has long-term side effects? There's not a lot of data looking at this, but probably the best is this fairly large study trial or comparative analysis by Al-Chaya, who's really the grandfather of autoimmune hepatitis and written a lot of all the seminal articles that described how to treat this disease several decades ago. So this study looked at two groups of patients considered to have non-severe disease. There was a group of patients with severe disease, and in the non-severe disease, there were many people that either didn't want treatment or they were not felt to require treatment because their disease was felt to be mild. And there were 21 patients in that group. There were 116 patients that were treated with mild disease, and then there was the severe group. The age range was about the same. You can see the liver transaminases in the untreated group fairly similar, 90 to 100, whereas in the severe group, it was much higher, which is typical for severe disease. The bilirubins were minimally elevated in the non-severe group. The IgG levels were much lower because there's less inflammation going on, and none of the patients had bridging fibrosis. So again, mild fibrosis, mild inflammation. Now, if you went ahead and treated these people with non-severe disease, half of them you could keep in remission with normal liver transaminases. And if you just kind of left them and didn't really do anything, these people with untreated mild disease, about a quarter of them did progress to hepatic death or required liver transplantation down the road. About a third developed cirrhosis, and I'll come back to that in a minute. But, in general, they did pretty well and not too dissimilar from the patients who were treated. If you look at the percentage of patients who develop cirrhosis, you see an interesting point that's well been recognized with this disease. And even though the disease is being treated, the severe patients are being treated, the non-severe disease patients are being treated, about a third of patients with autoimmune hepatitis will progress to cirrhosis, even if they're treated with immune suppression, and even if their liver enzymes are maintained normal throughout decades of their course. They simply smolder with very low levels of inflammation, but normal liver enzymes, and eventually develop cirrhosis. And so autoimmune hepatitis is not a disease that you cannot continue to follow. You can't send these patients away on immunosuppression not to be followed. You've got to constantly monitor them. make adjustments in their immune suppression as necessary, and keep in mind that about a third of these patients will progress. These days, the best way to monitor these patients for disease progression is with FibroScan. And whether our patients with mild disease are treated or untreated, and we certainly have many in our practice that are untreated, we monitor them with FibroScan. And if they do show evidence, and we monitor them with FibroScan annually, and if they do show evidence of fibrosis progression and they're in the untreated group, then we will initiate therapy to try to slow down disease or halt disease progression. Obviously, if the patients are already on therapy and they're showing evidence of progression, hard to know if you should rebiopsy and be a little bit more aggressive. And this comes to all the little different nuances of the disease, and everybody handles these a little bit differently. Many of you in the community would probably opt to refer these patients to expert hepatologists with more experience. The other issue about immunosuppression is that it's not always tolerated with patients. They can get infections. They can become intolerant to immune suppressive drugs, either with pancreatitis from azathioprine, neutropenias with azathioprine, or mycophenolate, CellCept, and about 11 to 14% of patients with treated disease, whether it's mild or severe, end up stopping their immune suppression over time. Autoimmune disease is a chronic disease. 80% of patients will relapse if the immune suppression is discontinued. So you need to tell patients up front this is a lifelong problem, and they need to be on immunosuppression long term, usually lifelong. Fibrosis progression will still occur in about a third despite having normal liver enzymes on treatment. And in those patients that really want to stop, how do you decide which patients can come off treatment and not relapse? You can see there the patients with completely normal liver enzymes, only 60% will relapse, about 40% may not relapse. In my experience, they'll eventually relapse. It may take another 5 or 10 years down the road, but they'll eventually relapse. But if you want to try to get them off therapy, there's two ways to do it. Simply stop, and if they relapse, they need to be retreated and recycled on prednisone. Or you could rebiopsy them, and if you see evidence of inflammation, you know they're going to relapse, and so there's no point in taking them off. Generally, I find when you discuss this with patients, they sort themselves out very quickly. If they don't want to rebiopsy, they'll go for the trial and error, or they won't want to stop. Or if they don't want to get recycled on prednisone, they'll ask for the biopsy, and if there's inflammation, they won't want to stop. So talk to your patients about the issues, remind them it's a chronic disease. Relapse is very high if you stop, but if they want to stop, you can certainly offer them to stop and then retreat and recycle with prednisone or rebiopsy. I want to talk about a different form of autoimmune liver disease or autoimmune hepatitis, and that's autoimmune associated hepatitis. And a lot of people get confused by this. And these are elevated liver enzymes found in patients with other systemic immune disorders, typically thyroid disease, lupus. And it was in this process was initially described in patients with lupus, but I've seen it in patients with multiple sclerosis, psoriasis, and almost ulcerative colitis. Almost any autoimmune disorder can have an autoimmune associated hepatitis. Elevated liver enzymes are found in about 20 to 60% of patients with autoimmune disease. Drug-induced liver injury is the most common cause, and it's usually due to the medications utilized to treat the autoimmune disorder. True coexistent autoimmune hepatitis, which can occur in any autoimmune disease, coexistent, is only really seen in about 10% of these patients. What's much more common is this entity of autoimmune-associated liver disease. Occurs in about 25% of patients with other systemic autoimmune disorders. Autoimmune-associated hepatitis is not autoimmune hepatitis. These patients present with mild elevations in their liver enzymes. The total bilirubin is normal. They either have none or very, very slow fibrosis progression. Progression to cirrhosis is extremely rare. And on liver biopsy, you would see a very, very mild, non-specific portal inflammation, not the piecemeal necrosis, not the interface hepatitis, not the lobular inflammation you would see with true autoimmune hepatitis. A very, very mild form of histologic inflammation. You don't treat these patients. You monitor these patients, and the best way to assess them is with fibroscan elastography, and we do that every year to monitor for fibrosis progression. And in my experience, fibrosis progression in these patients is very, very uncommon. They usually have no fibrosis at all at the time of histologic evaluation or fibroscan. In fact, my first line would be fibroscan, and if they have no fibrosis on fibroscan, I might not even do a liver biopsy initially. I would just follow them for over time. And if they had elevated liver enzymes for several years, maybe then intervene with a biopsy just to make sure that the disease was very mild. So this chart compares autoimmune-associated hepatitis with true autoimmune hepatitis. And this is from the paper that initially described this entity in lupus-associated hepatitis, as it was initially called. You can see in lupus-associated hepatitis, there's low complement levels, 90% are ANA positive, but it is very rare in these patients to have SMA or anti-LKM, but they do tend to have an anti-ribosomal P antibody in these autoimmune-associated hepatitis, whereas in true autoimmune hepatitis, you don't really see anti-ribosomal P protein. Again, their histology is very mild, with typically no fibrosis, whereas the autoimmune hepatitis is what we've been talking about before, a more severe presentation histologically. I want to move now on to primary biliary cholangitis. One of the most important things we've really learned about PBC in the last several years, maybe 5 to 10 years, is the impact of alkaline phosphatase and bilirubin on survival. And this is a landmark study by Lemmers that is now frequently quoted as a reason why we want to treat PBC down to normal alkaline phosphatase levels. And you can see here on the left panel, this shows threshold elevation in alkaline phosphatase from 1 to 5 times upper limit of normal. And if we look at the patients over at initial baseline after 1 year and 5 years, it looks at their hazard ratio of requiring a liver transplantation or death. So if the patient has very high alkaline phosphatase, 5 times upper limit of normal, let's just round that off and say that's 500. That patient has a significant risk, about a 1.5 hazard ratio of requiring a liver transplant. On the other hand, if they've had that elevated alkaline phosphatase for 5 years, despite treatment, and then they have a 4-fold or higher risk of requiring a liver transplant or dying from cirrhosis. And you can see the higher the alkaline phosphatase and the longer that alkaline phosphatase has been elevated, the higher the likelihood they're going to have disease progression and require liver transplantation. The same relationship is present for bilirubin on the right-hand panel, although it's even more pronounced. And having a bilirubin level as low as 2, which is 2-fold elevated, because normal bilirubin is about 1 or under. So a bilirubin of 2 equates to a significant hazard ratio of disease progression, and that risk of disease progression increases year after year after year as long as that bilirubin remains elevated. The higher the bilirubin, the higher the rate of requiring liver transplant or developing liver failure and death. And so even mild elevations in bilirubin are very strongly significant of disease progression. And based upon this data, this is why we want to treat PBC aggressively down to elevated, not minimally elevated, but normal levels of alkaline phosphatase and bilirubin. And that should be considered our goal of therapy in this disease. First-line therapy for PBC is ursodeoxycholic acid. This has been around since the 1990s, so 30 years of experience with urso when it became the first drug ever utilized and shown to be effective, rather, and approved by the FDA and EMA for PBC. This is the landmark study of Poupon, published in the mid-1990s, and patients were randomized to either placebo or UDCA, ursodeoxycholic acid, and at 2 years, the placebo patients then had urso added. Now, there's two very interesting things you can see by this graph. One is that if you started on urso from day one, over the first 2 years, there was not much improvement in survival. It was about the same. And the patients that had pretty advanced disease, they ended up decompensating, needing a liver transplant or die. And the patients that had milder forms of the disease, they continued on and continued to do well. And only after 4 years, 25% of the patients required liver transplantation or ended up with death. On the other hand, if you delayed the start of your urso for 2 years, these patients didn't really catch up. They had disease progression over those 2 years, and the disease didn't get better with urso. So what this is telling you is that once you get that initial diagnosis of PBC, you really need to start urso right away, because the sooner you start urso, the more you're going to prevent any disease progression. And once you start to get disease progression, from this data, it doesn't look like it's reversible. You still have increased mortality compared to if you had started urso years sooner. The second graph on the right shows you the response of the alkaline phosphatase to urso. And in general, patients will generally get about a threefold elevation or threefold decline in the alkaline phosphatase. The average alkaline phosphatase back in the 1990s was about 4 to 6 times elevated elevations of normal. And you can see that in the patients on the placebo, they really didn't have much change in their alkaline phosphatase over 2 years. But adding urso, there was a marked decline, about 50% decline in alkaline phosphatase in the first 3 months, and then a very slow further decline in alkaline phosphatase thereafter. In general, the alkaline phosphatase decline plateaus at about 6 to 12 months. It doesn't go down much more after 12 months. It kind of drifts down a little bit in some patients, but you get your biggest bang at the first 3 months and then a little bit more after 6 and 12. And so if you're monitoring patients with urso, and you kind of see that big drop in 3 months and then it's starting to plateau, you don't necessarily have to wait a year to add second-line therapy. Once the patient is plateaued and you see that at 6 months, comparing your 3 and 6 month value, there's no reason why you can't move forward and start your second-line therapy for PBC earlier. And that's the point of this slide. The other point is that not a great deal of patients with urso get a full response. Your alkaline phosphatase If it's really more than about 200, you're not going to get a full response with URSO. And most of your patients are going to be left with persistent elevations in alkaline phosphatase, and are then be candidates for second-line therapy. This slide shows a clinical response to URSO. And if you have more than a 40% decline in your alkaline phosphatase from baseline, which most patients with URSO will get, the average decline, I said, is about 50%. So most patients will get at least a 40% decline. You can see there's a significant reduction in need for liver transplantation and a significant improvement in survival in patients that are treated and have a good response to URSO. We now have second line for URSO, and we have 3 drugs to choose from. Maximal effectiveness from URSO, as I mentioned earlier, achieved after 6 to 12 months. So right away at 6 months, you should be thinking if your patient is a candidate for second line therapy. The response definitions identified in all 3 of the studies that led to approval of these 3 drugs was an alkaline phosphatase greater than 1.67 times upper limit of normal, a drop in alkaline phosphatase by 15%, and normal bilirubin. And the criteria for non-response was an elevation of alk phos more than 1.67, and the goal of therapy was to drop it under that value. There are 3 drugs that are now FDA approved as second-line therapy. The first, obeticholic acid, approved many years ago. This is an FXR, farnesylfarnesylide X receptor agonist, which decreases bile acid synthesis and increases bile acid secretion and flow. Its major drawback is that about 50% of patients develop itching or worsening of their itching. As you know, itching is a common side effect of PBC. Seladelpar and elafibranor are both PPAR receptor agonists. Seladelpar is an agonist of the PPAR alpha variety, whereas elafibranor affects both the alpha and delta PPARs. They both decrease bile acid synthesis. They are both anti-inflammatory. And the PPAR alpha delta also enhances metabolism of fatty acids and glucose. Seladelpar in particular has demonstrated a significant reduction in pruritus or itching in patients that had itchings and were treated with this drug. Elafibranor demonstrated a mild reduction in itching, but was not clinically significant in all of the itching scales, and did not meet the definition as significant reduction in itching in their FDA package insert. This is the data with obeticholic acid. In the study, patients were treated for 6 months with 5 milligrams. At the end of 6 months, patients were randomized. Those patients that still had elevated alkaline phosphatase above 1.67 were randomized to stay on 5 milligrams or were increased to 10 milligrams. Then there was a group that started on 10 milligrams from the start of therapy and continued. And one group was placebo. So 3 arms, placebo all the way through for a year, 5 milligrams. If you didn't respond, you went up to 10. If you did respond, you stayed on 5, and then 10 milligram arm. At 6 months, you can see that better response occurred with the 10 milligram group than the 5 milligram group. But when you increase the 5 milligram patients that didn't fully respond up to 10 milligrams, by a year, both the 5 escalate to 10 and the 10 milligrams from the start of therapy had identical responses of about 46%, compared to placebo, where only about 10% of patients responded with that composite endpoint reduction in alk phos to under 1.67, more than 15% reduction in alk phos and normal bilirubin. So because of that, the FDA approved obeticholic acid at a starting dose of 5 milligrams. And if your alkaline phosphatase doesn't respond fully, you can then increase to 10 milligrams at 6 months. If you look at the change in alkaline phosphatase on the right-hand side, you can see both a prominent, significant response in alkaline phosphatase to both the 5 milligram increase to 10 milligram and the 10 milligram dose. And you can see reductions in liver transaminases as well. Complete normalization of alkaline phosphatase with obeticholic acid occurred in 7% of patients compared to no patients treated with placebo. The next drug is a seladelpar. This is the PPAR alpha drug. And you can see compared to placebo, where 20% of patients responded, 62% of patients had that composite response reduction in alkaline phosphatase to under 1.67, more than a 15% reduction in alk phos and normal bilirubin. And alkaline phosphatase normalized, which remember, that's our ultimate goal of therapy, normalized in 25% of patients compared to 0% of patients treated with placebo. The right-hand frame shows the response to itching, the itching scale on, and you can see this is the change in itching. The placebo-treated patients had a slight reduction in itching during the course of therapy, whereas the patients treated with seladelpar had a significant reduction in itching at 3, 6, 9 months, where the effects seemed to then plateau. Elafibranor, also now FDA approved for the second-line treatment of PBC. 51% of patients achieved the composite endpoint that I've mentioned several times earlier, compared to only 4% of patients treated with placebo. 15% of patients normalized alkaline phosphatase with seladelpar, compared to no patients treated with placebo. And the right-hand panel shows the very brisk, rapid decline in alkaline phosphatase that you see with elafibranor. Within 1 month, it's already a 35% reduction in the alkaline phosphatase, and it pretty much plateaus at that point. It's important to realize that patients with PBC have several extrahepatic manifestations, and one of the most significant is osteoporosis. Osteoporosis is much more common in women with PBC in every age group, as you can see there in the bar graph, and therefore preventing osteoporosis and fractures is imperative in women with PBC, in men with PBC. They need to have regular assessment of bone densities, and everybody with a diagnosis of PBC should have a bone density performed soon after their diagnosis, and then be treated with calcium and vitamin D supplementation. If they've already developed signs of osteopenia, they should strongly be considered for treatment with a diphosphonate before they develop osteoporosis. Because once you develop osteoporosis in PBC, very, very difficult to reverse it. And these patients will therefore be at risk for fractures. In the graph, you can see the percentage of patients develop various with osteoporosis and how it increases in every age group. Important to remember that teeth are also affected by calcium loss. There's increased rate of dental caries in women with PBC, in women and men with PBC. They need to stay very, very hydrated, drink lots of fluids, have good oral hygiene, and they need regular dental visits and regular cleaning, more so than the average bear, to prevent dental caries from developing. Once you start to get dental caries in this disease, they're not going to be reversed very rapidly. Let's now move on to our third autoimmune liver disease, sclerosing cholangitis. This can be divided up into large duct disease, And these are diagnosed by the demonstration of strictures and beating in large to medium-sized bile ducts. MRCP is typically diagnostic. ERCP is rarely needed. Liver biopsy not needed except for staging. Small duct PSC, the diagnosis can only be suspected. The alkaline phosphatase is elevated with or without elevations in liver transaminases. You need to exclude drug-induced cholestasis, a cholestatic hepatitis. Cholangiography with MRI is normal, no real reason to do an ERCP. And because you have unexplained cholestasis, these patients tend to get a liver biopsy. And this shows typically portal fibrosis, where the fibrotic area is much greater than degree of inflammation. And I've shown you a typical liver biopsy of a patient with small duct PSC there on this slide. And you can see the increased portal fibrosis, portal expansion with fibrosis, with very minimal nonspecific inflammation. When I see this, I think of PSC. The prognosis of PSC, we now know, is related to alkaline phosphatase, just like it is in PBC. And this shows similar data to what I showed you to PBC. The longer you've had that alkaline phosphatase, the higher the alkaline phosphatase, the more severe or the more reduced is the survival. And you can look at biopsy as well. The more fibrosis on biopsy, again, the more they've already progressed, the more they're likely to progress, and the reduction in survival. This data comes from a study of lysyl oxidase type 2, which is an anti-collagen drug. The study was shown to be non-effective in patients with PSC, and so the data were combined to produce this natural history data. There's a strong tendency to perform ARCP in patients with PSC, and I want to strongly recommend that you try to not do this unless an ERCP is strongly indicated. You may see strictures, but if you stent them, it's not going to alter the natural history of the disease. An ERCP and placement of stents should be reserved for patients with symptomatic disease or persistent jaundice, which does not relent. Jaundice tends to be intermittent in this disease and associated with intermittent cholangitis, which can be treated with antibiotics, and then the jaundice and liver and cholangitis will resolve. However, unrelenting jaundice and a dominant stricture would be an indication, and more severe cholangitis with biliary sepsis would be an indication to put a stent. You don't want to put a stent in somebody that's asymptomatic because it may lead to chronic cholangitis, intrahepatic sepsis, and accelerate the need for liver transplant. What I've shown you here in these tables is data from 97 patients with a mean year of 5 years of monitoring, 5.2 balloon dilatations of strictures, and it really didn't impact the natural history of this disease at all. No significant change in liver transaminases, alkaline phosphatase, or bilirubin over 5 to 10 years of follow-up. URSO and high doses has been tried, but shown to be deleterious. This is a landmark study of high-dose URSO sponsored by the National Institute of Health. And actually, high-dose URSO led to an increased risk of death or need for liver transplantation, 3.3-fold higher risk, and a 4.4 higher risk of colon neoplasia in these patients. So based upon this data, we should not really use URSO at any dose in patients with PSC. Some patients can have overlap syndrome. Overlap syndrome is defined as features of autoimmune, PBC, and PSC, kind of like in a scrambled egg presentation. You've got serology that's consistent with one of these diseases, but liver transaminases that look like a different disease. For example, patients with elevated liver transaminases that look like, and a relatively normal outphos that look like autoimmune, but the AMA is positive. or elevated alk phos, normal transaminases, but the smooth muscle is positive. So these patients may have an autoimmune overlap syndrome. And you can have overlap syndromes with autoimmune and PBC. You can have autoimmune cholangitis, which is bile duct irritation that looks like an autoimmune disease, or you can have abnormal cholangiogram with autoimmune-like serologies. The only thing that what's essential in this disease, in this overlap, in sorting out overlap disease, is you absolutely have to do a liver biopsy to know what to do and to know how to treat it. The biopsy dictates your treatment and dictates what you will call the disease. If the presentation is an overlap, but the biopsy shows autoimmune, you change your diagnosis to autoimmune and you treat it like autoimmune. If your biopsy looks like PBC with cholangiopathy, you change the name of your diagnosis to PBC and you treat like PBC. Finally, a word about IgG4 associated cholangitis. IgG4 is part of the spectrum of IgG systemic disease. And these patients have marked elevation in IgG. They have inflammatory fibrosing disease involving the pancreas, bile ducts, salivary glands, lymph nodes, and the retroperitoneum. 7% of patients with so-called PSC, with strictures, actually have IgG4 cholangitis. These patients, the strictures look different than the strictures of PSC, and I've shown you the drawings of these differences in strictures. The typical strictures of patients with PSC is this string of beads appearance, small little balls of strictures separated by short little intervals of bile duct narrowing. In contrast, IgG4 related strictures are these long sausage-like dilatations with intermittent long strictures, as shown here in the cartoon or the drawing. The important thing is that IgG4 associated cholangitis responds very, very nicely to corticosteroids, prednisone, and second-line therapy, mycophenolate mofetil. In the table, you can see patients with IgG4 associated cholangitis. 97% of them had a decline in their alkaline phosphatase with steroids. 61% normalized the alkaline phosphatase, where only 19% of patients with typical PSC had a response to steroids and nobody developed a normal alk phos. When you finally taper off prednisone, half the patients with IgG4 relapse. However, 97% respond again with retreatment with prednisone. You would then add mycophenolate as second-line therapy and taper the prednisone, leaving them on mycophenolate. And I have several patients where that's been successful. If second-line therapy with mycophenolate is not successful, I would refer the patient to your favorite rheumatologist who will treat IgG4 disease with rituximab. So, take-home points for autoimmune hepatitis: liver biopsy is really essential and needs to be performed before you're committing a patient to lifelong, long-term immune suppression. Some patients with autoimmune hepatitis have a very mild form of the disease, and they may be better off without immune suppression, at least for several years. Autoimmune-associated liver disease is not autoimmune hepatitis and does not need to be treated, but needs to be observed. Overlap syndrome needs to be diagnosed with a liver biopsy. Our take-home points for PBC is that diagnosis is based upon two of the three criteria. Typically, elevated alk phos and a positive AMA. Liver biopsy is not needed. Survival of PBC is directly related to alk phos and bilirubin, and any elevations in these is significant and requires treatment. Add a second-line agent if the alk phos is not normal within 6 to 12 months, and don't let these patients progress. And finally, our take-home points for PSC: survival is related also to the alk phosphatase level, and the degree of fibrosis. ERCP and stenting strictures should be avoided unless cholangitis is present. And all patients with PSC, especially those with atypical strictures, need to be tested for IgG4 and, if found to be positive, treated for IgG4 disease. I'd like to thank you all for your attention today. And I think we can answer some questions. Is that right, Sanjaya?
Yes. Thank you, Dr. Shiffman. This was wonderful, and I really would like to take this moment to express our heartfelt gratitude to you for sharing your time, expertise, and insights with us today. The topic is now open for discussion. Dr. Shiffman, if you can unshare your screen so that we can see everyone. And please raise your hands. If anyone wants to ask the question, please raise your hands and I will go in order. We already see some questions are in the chat box, so I may invite those questions first. Dr. Sivaram Singh, if you're still here.
I'm here.
Yeah.
Yes, please.
Can you hear me?
Sometimes in a patient presenting with ALS, there can be confusion if the viral markers are absent. Whether you have a viral hepatitis with AIH presentation or whether it's due to, whether it's AIH or it is ALS with viral hepatitis. So, you have any tips for such a
So, if I understand,
situation?
I just want to summarize what I think the question is. We have a patient with viral markers as well as markers of autoimmune hepatitis. Is that correct?
No, I think there are no markers of viral hepatitis. They are absent.
Okay. And so we have an ALF presentation with
Yeah.
markers of autoimmune hepatitis. Is that correct?
Even autoimmune hepatitis is weakly positive. So sometimes you have confusion whether before you start treatment, whether it's AIH acute presentation or whether it is ALF due to viral hepatitis.
Okay. So if the viral markers are negative for viral hepatitis A, B, C, don't forget hepatitis E. In many parts of the world, particularly in India, Caribbean, Africa, hepatitis E is not uncommon at all. And make sure you get all your serologies. And don't forget, even in the US, I've seen severe hepatitis from hepatitis E. So once you've excluded all causes of hepatitis in the patient, you need to also exclude drug-induced liver injury, which is a significant contribution of acute liver failure. It's important to realize that steroids do not affect drug-induced do not impact survival in acute liver failure due to really any cause except true autoimmune hepatitis. If you have markers of autoimmune hepatitis in the setting of acute liver failure, it's not unreasonable to try steroids. But at the same time, if they really have acute liver failure, you need to consider them a transplant candidate and transfer them to a transplant center, or at least do a cursory workup and communicate with your transplant program. If there are no markers for autoimmune or viral hepatitis, and the patient has a presentation of acute liver failure, don't forget to use IV N-acetylcysteine, which is the only treatment that has been shown to improve life expectancy in patients who don't receive liver transplantation.
Yeah. All right. So we have some other questions as well in the chat box. I see Dr. Methani.
Good evening. So my question is, sometimes when we start steroids for autoimmune hepatitis, there is an initial increase in the liver enzymes. So I recently had a patient with AIH cirrhosis, biopsy proven, typical histology, IgG in the range of 4, ANA 1:320. Then we started her on 40 milligrams of prednisolone, and the liver enzymes increased from 300s to 900s in the next week. And then there were no other features of any drug-induced liver injury, any infection or any decompensation. We tested for CMV, other viral hepatitis also. And patient was clinically stable, so we continued the steroids. And then over next 2 weeks, the enzymes have come down to 100. So I wanted to ask whether have you commonly see this type of presentation or it's a rare thing, and how do you decide whether to continue steroids in such cases or to stop them?
So we have seen that presentation before, and it's usually due to the fact that you picked an initial dose of prednisone, which was just not enough to control the disease. The disease is flaring. You picked it up when the liver enzymes were 400. You started what you thought was an appropriate dose for 400, but if you would have seen the patient a week later, they might have been, or 2 weeks later, the liver enzymes might have been up to the 800 or 900, like that happened. So we recently actually just saw a patient like this. And what we did is we increased the dose of prednisone from 40 to 60, and then the liver enzymes started to come down, and we went through the normal tapering process. What's much more common is that you start at a dose, and then after 2 weeks you drop, and then the liver enzymes rebound right away. And you can, at that point, you can either just stay the course of 40 and not continue your taper down to 20, or you can go back up on the dose. The key to treating autoimmune hepatitis early on is to know that you have the correct diagnosis. The serology is positive, but most importantly, you have characteristic histology. And this is why liver biopsy is so important in this disease. If you see severe inflammation, piecemeal necrosis, interface hepatitis, lobular inflammation with collapse, again, the more severe the histology, the more likely it's going to require a higher dose of prednisone. So your liver enzymes in your patient was probably only about 400, but I'll bet you the histology was more severe than that. And if you would have started at the higher dose, you may not have seen that. But again, you did the right thing. You continued on with the therapy, and the patient eventually responded. And that's very, very typical of this disease. The vast majority of patients respond. There's lots of different cookbooks for autoimmune hepatitis, and pretty much all of them work. And there's only a couple things you can do that will cause you to not get a good response, and I've outlined them.
Yeah, I agree. So I also increased the immunosuppression from 40 to 50. I was a bit skeptical to increase it further because the patient had cirrhosis. So that's why I was scared to precipitate decompensation. But then she responded to 50 mg.
Probably, it'd be unlikely to precipitate decompensation with higher doses of prednisone. But I mean, obviously, the higher the doses, the higher the risk of infections.
Infections, yeah. Thank you.
Thank you very much. May I invite Kenan Moral, Dr. Kenan Moral?
Thank you very much for this excellent presentation. My question is actually regarding a patient. It's very rare, but he's actually we have given him rituximab therapy because he didn't respond to tacrolimus therapy, and with rituximab, we actually sustained the patient within the normal range. My question is, how long can we give this therapy? I know it's very rare in the setting of autoimmune hepatitis. Recently, there was a multicenter study from Spain showing the results of rituximab, and we should consider actually stopping the therapy because at some point hypogammaglobulinemia also develops, but also on the other side, you have the risk of relapse in those patients. Thank you.
Well, I've never used rituximab. You're right, there is a study, but I've personally never used rituximab for autoimmune hepatitis. But there are patients that are very, very difficult to keep their liver enzymes normal. In my practice, where we're a referral center for lots of gastroenterologists, we tend to get all these difficult cases. So we have a much higher percentage in my population of these kind of, let's just call them refractory autoimmunes that don't fully respond to therapy compared to the typical patient, which really responds very well. But in these refractory cases, my go-to is a calcineurin inhibitor, particularly tacrolimus, and the vast majority of these patients respond to tacrolimus with or without mycophenolate mofetil. Sometimes you can push your mycophenolate up to 2 grams a day, 1,000 BID. We get almost all of our patients to fully respond. Sometimes you'll have sometimes you'll have a patient, however, their liver enzymes come down to near normal, but they're not normal. And the question is that good enough? And sometimes what will be very, very helpful in that patient is a repeat liver biopsy. And you'll actually see a great response, even though the liver enzymes are still a little bit mildly elevated. And then you just go run with that and follow the patient long-term with FibroScan. The one thing you don't want to do in a patient that's refractory is keep flogging them with steroids after steroids and keep them on 20, 30, 40 milligrams of prednisone long-term, just trying to get those liver enzymes down to normal. At some point, you have to say, this is not working. And my cutoff is like, approaching a year. If you don't got normal liver enzymes on prednisone with or without azathioprine or Cellcept after a year, they're not going to normalize, and you need to move on to a third line of therapy. And then for me, that would be a calcineurin inhibitor, typically tacrolimus, which works very, very well.
Thank you. Dr. Moral, which country you belong to?
I'm from Turkey, actually. Yeah, we have given the patient tacrolimus too, dear professor, and we have combined it also with MMF, and the liver enzymes were still not going down. Also not down into they were over 100, I think 150 to 200s like that. And at the end, we gave, it's really, really rare, I know, but right now the patient is in a very good condition, but how are we going to proceed? It's a question mark. So I wanted to ask. Thank you very much.
Yeah, no, I think that's good. I think what I would have done after that point, I would have said, I would have questioned if something is wrong and repeat the liver biopsy. Did you do that before using rituximab? You did.
Yeah, we did it. Yeah.
And you saw a pretty severe aggressive hepatitis still.
Yeah. And within the histological,
yeah. And was it a rare type, not mitochondrial, smooth muscle positive?
Yeah. Yes.
Okay. Yeah, I mean, that is uncommon. That is very uncommon.
Yeah.
Thank you. Thank you. May I invite Dr. Jagam Abbas from Washington? Dr. Abbas, please.
Thank you very much. Nice presentation. I just wanted to know what's your experience of using fibrates in patients with primary cholangitis like fenofibrate or bezafibrate, and when do you use steroids in patients with primary cholangitis?
Steroids with PBC?
Yeah.
Okay. So we actually have a somewhat limited experience with fibrates. We do have some patients on them. And the response rates are very good. And there are several articles, particularly from the Miami group, which show very, very nice response to fibrates in PBC. There are also several studies in Europe using fibrates. There's really interesting preliminary data on combining obeticholic acid with fibrates. The response rates are very, very high, approaching 80% normalization in alkaline phosphatase. And without any itching, the fibrates completely eliminate the itching that's associated with the obeticholic acid. And I know Alpha Sigma, which now owns that product, is considering a combination study of obeticholic acid with a fibrate combination single pill. That study has not yet been initiated that I'm aware of. They've been talking about it for a while. So we'll see if it ever gets off the ground. Hopefully it will. It looks like a very good combination therapy. In terms of prednisone, PBC will respond to prednisone. It's an inflammatory disease. It's inflammatory cholangitis. And if you use prednisone, the patients will respond, their alkaline phosphatase will come down, but it's not in the algorithm for treatment because of the accelerated osteoporosis that you see in these patients, and which would be further exacerbated by prednisone, by corticosteroids.
Thank you for that question, Dr. Abbas. Let's move on to Dr. Rishi Samant from Osner.
Hey, Dr. Shiffman. Great talk. Just two quick questions. What's the trough? What is the target trough you look in tacrolimus? And then how do you taper budesonide once you achieve remission?
So with budesonide, we'd usually use the 9 milligram extended release dose once a day. And we usually let that ride. You can over time reduce it down to 6 or 3, just depending upon the patient's response. Usually we're not going to use budesonide unless they've determined that they require long-term prednisone with a second-line agent. So almost all of our patients on budesonide is with a second-line agent to keep the liver enzymes normal. We don't usually use it as first-line in exchange or instead of prednisone. We use prednisone first and then try to get the patient tapered off steroids and on azathioprine or mycophenolate as single-line therapy, and the vast majority of patients can do that. If they can't do that and they need a steroid, that's when we would switch over to budesonide or a calcineurin inhibitor. In terms of blood levels for calcineurin inhibitors, I target 2 to 4 on the low side. And once the liver enzymes are normal, try, if they're at the higher end of that 2 to 4 range, slowly over time get them down to 2. And that's a dose that's very, very well tolerated, very effective. And I can tell you that we've seen almost zero kidney injury at those doses of tacrolimus.
Okay, thank you very much again for that question, Dr. Samant. Let's move on to, I see someone's initial name, RU. I don't have a name.
Sorry,
please introduce yourself.
You're Raj here. I'm from WA Perth. Great talk, Dr. Shiffman. The question I've got is in terms of with regards to different patterns of smooth muscle antibody. Now, our local laboratory tend to, termed, whether it's a V or G or a VGT pattern, and the tendency to consider VGT as the most diagnostic or highly suspicious of autoimmune hepatitis. What it does quite often is the weakly positive smooth muscle antibody V or G pattern in fatty liver or metabolic risks. There's always a bit of a dilemma whether they are, pure fatty liver or an overlap with autoimmune. So I just wanted your thoughts about, are these patterns important at all, or is it a standard practice? Or
okay, we don't really subtype our smooth muscle antibodies, and they don't really mean much to me personally. A smooth muscle antibody is suggestive of autoimmune hepatitis, and in the correct setting would lead to a biopsy to make the formal diagnosis. Number 2, you are absolutely correct. The amount of positive anti-nuclear and smooth muscle antibodies in fatty liver disease is staggering, and sometimes creates difficulty in knowing if you have fatty liver disease with autoimmune hepatitis or just fatty liver disease or just autoimmune hepatitis. And a lot of times we rely on FibroScan, the presence of metabolic syndrome risk factors. and clinical progression or response to dietary therapy. So if the patient loses weight and their liver enzymes come down, well, that means the liver enzymes were probably due to the fatty liver disease, to MASLD or MASH, and they really didn't have a coexistent autoimmune. If the liver enzymes come down, or if you have a patient with NASH, metabolic syndrome, and the liver enzymes are low or normal, that's probably, and they have serologies for ANA and smooth muscle, that's probably not autoimmune either, because the vast majority of patients with autoimmune, their liver enzymes are going to be normal. But sometimes the liver enzymes are elevated. The patient doesn't lose weight, as many of them don't. They don't respond maybe to treatment of their fatty liver disease with Resdifra. And then you have to second guess yourself and saying, well, maybe this is autoimmune, and at some point you're going to need to do a biopsy of the liver to really sort it out. And again, many of these patients will not have autoimmune; they will just have MASLD or MASH.
Thank you, Raj, for that question. Let us move on to Dr. Manas Panigrahi from India.
Professor Shiffman, excellent lecture, and thank you for that. And my question is three parts. That is, what is your take on when used to stuff that we are not going to use steroid in a patient of, that's a decompensated and severe liver disease, end-stage liver disease with autoimmune hepatitis, or else we should treat all the patient of autoimmune hepatitis having severe liver disease? That is first part. And what is your take on when the patient of AIH presenting as ALF, and when autoimmune marker like ANA is only positive and liver biopsy shows a lot of necrosis in it, there is no piecemeal necrosis, piecemeal interface hepatitis or something, lot of necrosis in it. And third part is, what is your take on seronegative PIH?
What was the last one? My take on what?
Seronegative
PIH.
Oh, seronegative AIH. Okay. So let's deal with that one first. About 20% of patients will have seronegative autoimmune hepatitis. They have elevated liver enzymes. Your serology for everything else is negative. You don't think they have MASLD because they don't have enough features, or they don't have any features of metabolic syndrome. And if your index of suspicion is high, you will obviously need a biopsy of that patient to make the diagnosis of autoimmune hepatitis, and the histology will be diagnostic. Some of these patients will present as cryptogenic cirrhosis. You do a biopsy and they'll just see bland fibrosis, but they had some autoimmune markers, and that's probably burned out autoimmune hepatitis, doesn't require therapy in that clinical scenario because there's no inflammation. I think I've answered two of your, the autoimmune, the acute liver failure. Yeah, I think, again, index, if you have high liver enzymes, it looks like autoimmune. You have coexistent autoimmune disorders. The liver enzymes are very high. You do a biopsy and there's a lot of inflammation associated with necrosis. You're not going to have pure necrosis with autoimmune hepatitis. All the necrosis is going to be driven by inflammation. If you see that, then you can use steroids in that situation. Acute liver failure from autoimmune disease is the only subgroup of acute liver failure patients that did not respond to N-acetylcysteine in the randomized NIH-controlled clinical trial, randomizing patients to N-acetylcysteine versus placebo. And that's because the treatment is immune suppression. You have to watch them carefully. If they have progression And if they start to respond, their INR starts to improve, their liver enzymes come down, their bilirubin starts to come down, and then you're moving away from acute liver failure. That's good. However, if the patient continues unrelentingly to have elevated liver enzymes, their INR goes up, they develop any evidence of hepatic encephalopathy, they basically need to be transferred to a liver transplant center and considered for transplantation, or they won't survive. So the treatment of acute liver failure from any etiology is transplantation. And once you really have all of the, there's a difference between severe aggressive autoimmune hepatitis and acute liver failure autoimmune hepatitis. One has liver failure with coagulopathy and HE. And once you get that, it's very unlikely you're going to reverse that with steroids. And you need to get that patient where they can get a transplant.
Thank you, Dr. Panigrahi. I know we have so many additional questions, but we have limited in our time. I'll only take one more question from Dr. Burma, who has been waiting to ask this for a while, and then we'll conclude the session. Dr. Burma, please.
Thank you so much. Dr. Shiffman, I have a quick question about autoimmune hepatitis. A patient who has biopsy-proven autoimmune hepatitis, and now the transaminases have normalized. However, her alkaline phosphatase is mildly elevated, around 130 or so. The bigger question is, her IgG continues to remain between 2,500 and 3,000, which is more than 1.5 the upper limit of normal. Given that transaminases have normalized, but IgG continues to remain high, would you go up on the treatment to try to bring the IgG down to normal as well? Thank you.
So this is already a patient with biopsy-proven autoimmune?
Yes.
Okay. I would consider that this patient may have PSC. I've seen several presentations of PSC in an autoimmune-like presentation with high liver transaminases, and high alk phos, or a moderately elevated alk phos, where the liver enzymes kind of overshadow the alk phos, and you don't really think about PSC early on. But they don't really respond fully to immune suppression, and the alk phos remains persistently elevated. So I would make sure you have an MRCP in this patient and exclude PSC. If PSC is excluded, I would probably rebiopsy the patient before I would go up on the immunosuppression, just based upon an IgG level. If the biopsy showed a relatively quiescent autoimmune hepatitis, I would be happy with that, and I would just monitor the patient with FibroScan. I'm not a big IgG guy. I look at it for the initial presentation, but I personally don't follow it that closely. It tends to usually mirror the liver transaminases, and when they come down, the IgG comes down. This is an atypical case, and in my book, atypical cases require histology. I'm heavy-handed with biopsy. I don't mind biopsying patients to help understand and make sure my therapy is correct.
Thank you.
Thank you so much.
Thank you, Dr. Shiffman, and thank you everyone who asked those questions. Those are important questions, and thank you, Dr. Shiffman, as well for your time and expertise. This was truly a wonderful lecture, and I think you covered so comprehensively AIH, PBC, and PSC with so many good take-home points that we'll all take it from here. And those who has missed these lectures, with Dr. Shiffman's permission, it will be there on the website. And you can always revisit and rehearse this lecture and go to the in-depth. Thank you, Dr. Shiffman, again. Thank you everyone for joining today, and we'll look forward to see you all in 2 weeks.
Thank you, Sanjay, for inviting me to give this and talk to your audience.
Thank you.